Welcome back. One of the beautiful things about health professions education is that each professional commits to educating the next generation of professionals behind him or her. And so many of you who have learned something from this case might find yourselves in a position of teaching clinical problem solving at some point in time in the future. So we're going to talk a little bit about some explicit steps you can take as you're using these skills to teach other people how to do what you've learned to do. And of course, the best thing is for them to actually take the course, but you'll be able to help them understand how to apply some of these skills right at the bedside, and that's going to be the focus of the next set of slides. So one of the things that's become increasingly apparent in teaching expertise is that content expertise is absolutely critical, as is teaching technique. But very important to successful educators is understanding how learners think. And we've been talking for the last 6 weeks about how experts think as well as how learners think in clinical problem solving. And we're going to show how you can peer into that individual's brain and help redirect them if they seem to be going in the wrong direction. So the clinical problem-solving strategies that we've been using, and particularly the compare and contrast thinking and vertical reading, provide a systematic strategy that help faculty understand the nature of students' problems as they face clinical problem-solving dilemmas. The structure also provides a nice way for students to self-assess and plan for self-improvement, not only in the moment in terms of rethinking how they prioritized a particular differential diagnosis, but also in planning for the types of reading that they might want to do after rounds or after they're off of a clinical service. So what if you're working with a particular individual, they give a presentation, and you ask them to engage in this clinical problem-solving activity, and they give you the wrong answer? Well, first you have to start back with a problem list. Were they able to do a simple problem list? If not, then the problem may in fact just be inattentiveness or memory issues. Those are harder to deal with using our structure, but at least you know what the problem is. If they can't process or develop illness scripts, then that's a perfect time for them to learn about the vertical reading, the Venn diagrams, and the compare and contrast thinking. And again, remember, as you take this information and use it in your daily work, knowledge bases don't increase just by pouring in new facts. They have to be organized in a way that will allow people to use those facts in the clinical environment. And so focusing and teaching them about vertical reading and about Venn diagrams, key differentiating and rejecting features, is the right approach to someone who can do the problem list but can't process it or develop illness scripts particularly well. If they can't prioritize, so say they're able to do the problem list, process and develop illness scripts, but really can't prioritize, it may be that they have a factual knowledge problem. Perhaps their illness scripts are incorrect, and you can actually test them on it. That's the beauty of an illness script. You can ask them to account for you when they offer a diagnosis that seems implausible. What is the epidemiology of that disease? Who gets it? What are the risk factors? What is the time course over which it presents? What is the clinical signs and symptoms that you think are going to be seen in most of the patients with this disease? And what type of mechanisms of disease might we anticipate to be present in this patient? Now, sometimes people get the right illness scripts, but find it difficult to let go of some of the features. And so a lack of understanding of key features might be another reason someone can't prioritize. And so these people work best if you take them back to the Venn diagrams and show them how diseases interrelate around a particular syndrome. Again, if they give you the wrong answer, rather than you giving them the fish, teach them how to fish. And teach them how to fish by encouraging what I call autocorrection. So ask them when they venture a disease that seems not likely, what does that disease typically look like? And force them to use the illness script format and the process descriptors. This helps the student identify their learning gaps and also plan to correct them. After all, if the student knows what the time course and classical signs and symptoms are of a particular disease, but doesn't understand the epidemiology, then you know you have to send them back to read about the epidemiology of that disease in contrast to other diseases that are being considered in the differential diagnosis. Students pick this up pretty quickly. You can teach them fairly quickly about illness scripts, and then you can ask them to identify their learning gaps using that illness script format. Another question you can ask with the wrong answer is, how does that illness script that you're describing compare with this patient? This forces them into a compare and contrast thinking and can give you some insights into where they're really struggling with what's the right way to prioritize a given presentation for this patient versus the disease in question. One of the nice follow-up questions that you can ask for this is, how does this particular disease explain this patient's symptoms? So what you're getting them to do then is, of course, take the patient information in front of them and access information in their brains and use it to build stronger networks. And in doing so and working out loud, of course, it helps you understand where there might be problems in their thinking. Finally, it's really important to stress key and rejecting features, and the best way I've found to do this is when they offer a diagnosis that really is a tier 2 or a tier 3 diagnosis, ask them to venture a guess as to what would have to be present to make this a tier 1 diagnosis. If they can do that, then it's pretty clear that they're prioritizing based on a clear understanding of what features would push a disease into tier 1 and what features would be present to push it down into tier 2 or tier 3. What happens with a learner who is able to present the history and physical, perhaps even go so far as to generate a patient illness script, but then doesn't have any pattern recognition or diagnoses to prioritize with that patient illness script? Well, the goal in that situation is to get the student to generate diagnostic ideas and then evaluate them using illness scripts. This is really important to not divert back entirely to hypothesis testing. So what we can teach them how to do is some forward thinking. So you could sort of teach them, for instance, if faced with a patient with thrombocytopenia, to sort of say, well, let's do some forward thinking around this. Is this destructive or productive thrombocytopenia? If it's productive thrombocytopenia, is a one cell line affected, or is there a pancytopenia present? If there's pancytopenia present, are there dysmorphic red cells or not dysmorphic red cells? So you can help them work through forward thinking to understand different diagnoses you might consider. You also might get them to think pathophysiologically to stimulate those previous memory stores that they put in place during their first 2 years of medical school or nursing school, asking them, how is edema formed? So don't have a differential for edema? Well, let's go back and sort of say, how is edema formed? Well, it's increased hydrostatic pressure, decreased oncotic pressure. Let's think about different diseases. Or you can revert to one of the many mnemonics on category chase that we call category chase, and we talked about that earlier. The key point of this, though, is to start with this to generate a reasonable list, but then go right back to the compare and contrast thinking and use that to prioritize your differential diagnosis so that you don't maintain this long list of differential diagnoses forever. That's at the bedside. But what about planning educational programs? Well, to emphasize compare and contrast thinking and to emphasize prioritize differential diagnoses, it's really important to begin to think about how we orient lectures and to begin thinking about a lecture that's focused on glomerulonephritis rather than a lecture that's focused on lupus. A broader lecture enables you to bring in multiple different diseases and to teach the residents and students by your role modeling how to always compare and contrast to remember important features of diseases. You can also assign readings in a vertical fashion. Instead of asking them to read about multiple sclerosis, ask them to compare and contrast between multiple sclerosis, myasthenia gravis, and amyotrophic lateral sclerosis. Encourage people to come back with key and differentiating feature identification. And then a really important way of testing understanding is to encourage your students to work together to build questions. Building questions and then having an expert analyze those questions for accuracy is a really excellent way to reinforce compare and contrast learning. And the students actually really enjoy this, probably much more than actually taking the test that has those questions.